So this masterly oration, actually this next would be tropical AKI. Tropical AKI, I think is a more relevant topic for physicians because we are dealing a lot of dengue cases, a lot of leptospira, scrub typhus, and definitely kidneys are involved in this acute infections. So it's my pleasure to announce that it would be delivered by Dr. N.P. Singh sir. Dr. N.P. Singh sir we all know, and he would be joining straight from Georgia, US. So I would try to connect him from Georgia, US right now. Yes, sir. Welcome, Dr. N.P. Singh, sir. So, sir, just unmute, sir. Let us unmute, kalo, sir. Sir, unmute, kalo, sir. Ashish, sound, yaar, sound. Ashish. Sir, we are doing, sir.
Moving on to our next session, now we would be inviting our chairs, Dr. Parkash, Gera sir, Dr. N.K. Govil sir, Dr. Lalit and Dr. Varun Verma sir to please chair our next session.
इतनी जल्दी काफी महंगा कार इंश्योरेंस लिया
Pankaj, can you hear me? Good afternoon, everyone, and after this masterly oration by I'm privileged to be a part of EDPA where this nephrology update is being held.
Bites, other food. There's no better person than Professor N.P. Singh to just deliver his talk on this particular issue. I'll welcome you, sir. Thank you.
Thank you, Dr. Gera, sir, and recording.
Pankaj, can you hear me?
Yes, sir. Yes, sir.
So thank you, Dr. Gera, for a wonderful introduction, and thank you, Pankaj, for giving me a chance to be with my friends and colleagues in East DBA, and I always feel that I'm a part of them. And today I'm going to talk on a very, very important topic, as sir has mentioned. And if this recording cannot be played, then I can go live and I can present my slides.
We'll try for recording first.
Yeah.
Take it.
अभी शाम तक आ जाओ
minutes on this. That what is my Georgia team from USA. I am thankful to the organizers, especially Pankaj, for giving me a chance. I bring greetings for you. And I know uh, this program is going to be successful because of the sheer organization ability, and I have a great faith in EDPA, and I always feel a part of it. So today I am going to talk to you on a very, very important topic. I know it is a full house on nephrology, but one of the very important thing which I am going to discuss is acute kidney injury in the tropics. I will be spending around 20-25 minutes on this. We all know that what is a tropical zone, and India, as you can see from here, that is a part of the tropical zone. Now, it extends from Tropic of Cancer and Capricorn is an area with an extreme heterogeneity. On one hand, we have Asian countries like India. On the other hand, we have South American and African countries. We also know that acute kidney injury is, as you must have heard by now, is a reversible decline in GFR, leading to retention of nitrogenous waste products. And also, there's an inability to maintain fluid and electrolyte homeostasis. This is one of the enigmatic problems. And the reported incidence can vary based on where do we have AKI, whether it is in community, acquired, or hospital or ICU. The incidence may vary from 25 to 80%. Now, how is AKI in tropical countries different from AKI in temperate countries? And we can differentiate this too based on the earning capacity of a country as well. So temperate country is typically represented by Western countries where we have a robust data, we have older age group more commonly affected. Patients are more likely to have a pre-existing comorbidity. There can be an acute or chronic kidney disease. Most of these patients are in ICU or hospital acquired, and they are multifactorial, and they have a high mortality. Also, AKI in tropical countries generally underreported. Most of this would occur either in the community setting or in the basic hospitals. The patients are younger. Often patients have no comorbidity, and it is referred to also as community acquired AKI. It is normally, as compared to AKI and temperate, it is of a single cause. Mortality, if not detected and treated earlier, can be as high as 40 to 70%. Though classically AKI, which occurs following gastroenteritis, the mortality is much less. So what are the common causes of tropical AKI? I would divide them into four important causes. First are the infections, and we know malaria, especially both Vivax and falciparum, leptospira infection, hemorrhagic fevers, infective diarrheas, HIV. Scrub typhus is now emerging as one of the very important cause, and so are other rare disorders. Well, plant toxins, mushroom poisoning, herbal medicines, Trapezium wilfori can all cause poisonings which can cause either AKI as a part of multi-organ involvement or AKI per se. We know animal poisons, chemicals are one of the important causes, and snake bite tops the list with scorpion skin, jellyfish sting, carp, gallbladder, or bile. Similarly, drugs like copper sulfate or chemicals, ethylene dibromide, again a very common cause, formic acid. We know a lot of which occurs, and then we have certain miscellaneous causes, including heat stroke, natural disaster, trauma, especially in a place where there is a fight going on, can also result. Let's start with the infections. Well, a patient with infective condition can present to us with various associated symptoms. So patient can present to you with fever and jaundice, and leptospira, malaria, dengue, yellow fever, etc. Rickettsial disorders can be the other cause, like differential diagnosis. Biphasic fever with thrombocytopenia, transaminitis, leptospirosis. We have continuous fever, severe respiratory symptoms. Of course, COVID now tops the list, but hantavirus is another important viral infection. We can have severe myalgia and acalculous cholecystitis, and all of us have witnessed dengue outbreaks where AK can be one of the manifestations. Scrub typhus is one of the most difficult condition to diagnose. I know Pankaj has made many a diagnosis by just by looking at the SCAR, and AKI can be a presenting feature, and malaria presents typically with fever, splenomegaly, thrombocytopenia, brucellosis. I think one of the most underdiagnosed condition is brucellosis, which can present with fever in exposed individuals, and so are bacterial diarrhea. So, what are the mechanism involvement? We go into the details of individual conditions, but we know there can be a direct involvement of kidney or the urinary tract by microorganisms. There can be a tubulointerstitial injury, toxicity. There can be an injury to glomerular endothelium, or there could be an injury to the collecting duct. There can be indirect involvement also, either in the form of hemolysis, rhabdomyolysis, hypovolemia, sepsis, and microvascular injury. And there can be drugs which we actually give to treat infections, but can also cause hemolysis or oculotubular injury. So we classically divide them into glomerular causes like immune complex glomerulonephritis. We know infection-related GN is one of the commonest glomerulonephritis seen in tropical countries. We can can have TMA or secondary amyloidosis. We can have typically leptospiral infections can have acute or chronic tubulointerstitial nephritis. We can also have vascular involvement in the form of TMA, and rarely a severe AKI can cause acute cortical necrosis. So this is the important slide comparing all the four important causes of infections causing AKI in tropical countries. So we can leptospira, the incidence varies from 10% to 27%. Subtypes again a very variable incidence, but AKI you can see is very common. Dengue, of course, not that common if treated early, especially with adequate hydration and fluid therapy, but still can vary up to 25%, and malaria can cause AKI. Generally, the endemic area, we know about it, and India, other Caribbean countries, South Africa, etc., are common endemic area. We know about these genuses. I'm not going to detail, and dengue virus, all four type 1 to 4, especially when the second attack occur, and plasmodium, both Vivax as well as falciparum can cause AKI nowadays. We know about reservoir factors, pathogenesis is in detail. We'll talk about these in greater details individually. Let's come to falciparum malaria. It remains one of the major tropical hazards, and AKI occurs in around 1 to 5% in all cases of AKI. And in terms of non-immune individuals, it can occur in up to 25 to 30%. It can be a AKI alone and a part of a multi-organ dysfunction also. One of the common manifestation of malaria-associated AKI is jaundice, which can present either because of hemolysis or liver involvement. Electrolyte imbalances are common: hyperkalemia, hypokalemia, hyponatremia, and other abnormalities, and volume depletion, GI bleeding, sepsis, nephrotoxic drugs, and hyperbilirubinemia. Though these all act as a precipitating factor. So here we see this is an infective erythrocyte. The malaria has affected this erythrocyte. We know these are the merozoites which are released. They cause cytoadherence. Now, one of the important thing is cytoadherence, which can cause capillary clogging. In addition to that, there's an immune response also. Malarial parasite can induce immune complex deposition and cause glomerulonephritis. And so is the release of the cytokine and inflammatory cascade, which can cause sympathetic activation, RAS activation, arginine vasopressin release. All this can give rise to AKI. In addition, we have indirect toxicity resulting in decreased renal blood flow like hypovolemia, hemolysis, rhabdomyolysis, hyperviscosity. All this combination of all these factors can result in a severe AKI and malaria. So obviously, the management essentially consists of giving them fluids. Blood glucose level has to be maintained. Acid-base status has to be maintained. Intravenous quinine or artesunate remains the drug of choice. Gametocidal therapy with doxycycline is also recommended. And what is important is to recognize this entity and treat aggressively at early stage. Again, sometimes, occasionally, these patients might require overall the outcome might be good, but once the patient goes into a so-called severe AKI, then these patients might require an intermittent or a continuous form of dialysis. And of course, depending on where the facility is and where is the AKI occurring, even PD can sometimes be effective. But earlier on, people used to resort to plasma exchanges and blood transfusion. So, when I was in Loknayak Hospital, one of the first cases of AKI occurring in patients with leptospirosis I saw, and we know it's one of the very important zoonoses, especially in the southern part of our country and even in Delhi now, it can occur. Well, there can be a direct contact with vectors like rodent, etc. But sometimes when there are floods, when there is a famine, then these things become important. Flooding, lacerated wounds, and history of contact with livestock is important. Again, there are various tropical countries which are affected, and its severity is associated with increased mortality. We know about Wheel syndrome, which is a leptospiral disease which causes multi-organ dysfunction, and that includes AKI. So typically, the presentation is non-oliguric. But I have seen one patient whom I have seen as AKI, and then he progressed on to develop a chronic tubulointerstitial disease, resulting in chronic kidney disease, and he probably required dialysis for almost next 10 years before he succumbed. Well, this mechanism is almost similar. So we have indirect toxicity in the form of hemodynamic instability, hyperbilirubinemia, rhabdomyolysis, and there can be a direct toxicity. So essentially, it involves the tubular interstitium and tubular epithelial injury, which can cause various mechanisms through toll-like receptors, through cytokines like TNF alpha, and all these can cause severity of associated AKI. There can be patient factor like age, comorbidities, and immune status, and there can be disease factor also. So there's a combination of these mechanisms can lead to the AKI, and typically we see these hemorrhagic blisters. And one of the manifestation of AKI in all both leptospiral and pregnancy snake bite is a severe acute cortical necrosis, which can be diagnosed earlier stages with a plain CT scan where you can see a rim of calcification around the kidneys. And this is the histopathology which shows totally damaged glomeruli. It is almost like a fibrotic band, and this actually requires patients to undergo dialysis long term for various reasons. So management again consists of trying to do a MAT, which is microscopic agglutination test, and direct culture. And of course, now recently some newer antigens have also been identified, which can be demonstrated for detection of leptospiral disease. Antibiotics are the mainstay. Oral antibiotics like doxy, amoxicillin, chloromycin, or erythromycin, or are given, or penicillin used to be one of the ceftriaxone is one of the treatment of choice. Doxycycline is also an effective prophylactic, and then there is a controversy regarding the use of steroids, but definitely when patients have a severe AKI, then renal replacement therapy may also be required, including ECMO in such situation. Well, here comes our dengue. We know that dengue outbreaks, and this year I am expecting that dengue might come back again because we had a lull last year and almost affects millions of people. And India is no example where, no exception where we have had a widespread occurrence because of climate changes and clear water collection. The clinical spectrum we all know ranges from asymptomatic disease to a severity of not only thrombocytopenia but evidence of plasma leakage resulting in hemoconcentration, and electrolyte imbalances are also common. A renal involvement can cause AKI, can include proteinuria, glomerular disease, atypical HUS, all electrolyte, all types of renal involvement can occur. Risk factors for AKI includes transaminitis, which can occur in thousands, metabolic acidosis, severe hypotension, nephrotoxic drugs, and patient factors like elderly, obese, and rhabdomyolysis. And AKI in dengue can have very, very high mortality. There can be a direct viral invasions of the kidney, and there can also be some indirect effects. ATN is a major result. Rarely we can have a GBM disease. We have cases of IgA nephropathy, and low complement associated lupus nephritis have been described. People have gone ahead and done histopathology, kidney biopsies, EM findings, but all this actually are theoretical in nature, and ultimately we need to understand that there is a cytokine storm which can cause severe hypotension, direct virus injury, rhabdomyolysis, there are interleukins, all this can cause AKI. Management again essentially consists of giving them fluids, and at the right opportunate time, and we know once a patient has been diagnosed as HUS, especially nephrologists like Dr. Balla and others know that eculizumab has been found to be effective. We should avoid non-steroidal antiplatelet. Well, HIV and AKI, I'm not going into a detail, but we know AKI could have occurred as a part of the direct viral infection called invasion in the kidney, resulting in severe HIV-related renal failure. But now, with the availability of the heart, that IVAN has reduced, but now we have so many other causes, especially opportunistic infection, chronic diarrhea, and other causes can cause AKI and HIV. As I said, medication again, one of the important causes due to crystalluria or obstruction, and potential risk factors are high viral load, reduced CD4 cell count, and successful prevention depends on optimizing immune status and aggressively treating them. Well, I can't go ahead with AKI in tropical countries without talking about COVID, though COVID is a pandemic and involves almost all the countries, but especially in our country, it can cause AKI both in the terms of asymptomatic phase, where there is a direct viral invasion causing collapsing glomerulopathy, complement activation, inflammation. It can also occur due to multi-organ involvement or due to fluid management, mechanical ventilation, nephrotoxic drugs. There can be organ crosstalk. One organ can affect the other. And there can be fever, sepsis, diarrhea, and hypovolemia. And AKI has been described as one of the common severe manifestations of COVID. Now let's change again to talk about toxin and poisons. Well, we all know snake bite can cause AKI both in terms of vipers as well as the other cobra. Both can cause AKI. Bee stings can cause AKI, and spiders and scorpion stings can cause. So I'm not going to the details of the type of AKI which we get and what causes it, what are the areas by which it can occur, and what is the characteristic of AKI. But definitely we know there are certain herbal toxins which can also result, especially related to herbal medicine. We all know about Chinese herbal medicine causing AKI, but there are certain plants or herbs like Zencola beans, star fruit, impella, raw bile carb have been, unless we talk about tropical AKI, we always talk about these plant toxin. They are very rare. In Delhi, I don't think we've seen many, but when I was in Jipmer, Pondicherry, we've seen many of these cases. And these are the active molecules. Star fruit can cause AKI due to oxalic acid. So the renal involvement occurs either in the form of intratubular obstruction or ATN, severe AIN, and of course, rare other manifestations. But snake bite has to be discussed for just next 2 minutes. It has the highest burden in Southeast Asia and some African countries. We know there are almost more than millions of types of snake species described, and there are 130 snake venoms which have been described, which are complex chemical compositions mixed with various enzymes, carbohydrate, lipids. These compositions depend on the type of snake, sex, habitat, external temperature, and venomous snakes are classified into 3 basic types: hematotoxin, neurotoxin, and myotoxin. And this is what can cause, various types. As I said, hematotoxin, neurotoxin, and myotoxin. They are present in Asia almost, except there are certain varieties which are present in Australia. All are present. And how does it cause AKI? When again, snake bite results in release of various enzymes of the body and their non-enzymatic protein. They can result in either a complement activation, causes glomerular disease. They can cause direct inflammation and rhabdomyolysis. We know some of the snakes can cause rhabdomyolysis. They can cause endothelial injury and cause TMA. This is one cause of severe ATN resulting in acute cortical necrosis. Well, the patients can recover from that, or patient can go on to develop chronic kidney disease. Well, early biomarkers are needed to diagnose and treat snake bite associated AKI. Elevation of NGAL have been found to end cystatin C. We know about these markers. And more importantly, the cornerstone for reducing morbidity and mortality include early investigation of antivenom, tetanus toxin, and appropriate volume replacement. Delayed timing of receiving antivenom can resulting in tenfold increase in incidence and mortality. And therapeutic plasma exchange has been used in some cases, but TMA, but not effectively. Regarding the plant toxin, I can only say that these are very common in certain villages, especially in African countries, in China, in other countries. It can cause variety of renal lesions, including tubular necrosis, cortical necrosis. Almost 25 to 60% of all cases of AKI from medical causes in hospitals in sub-African countries are associated with herbal medication, and such medicine are usually prepared under non-standard conditions and often contains many toxins which can cause. And already talked about this slide. I'm not going to go to this. Well, in the last, I think two important things: G6PD deficiency. We know it is common in some ethnic tropical populations, and acute intravascular hemolysis occurs because of the precipitation of hemoglobin when the red cells are subjected to oxidative stress in patients who are G6PD deficient, and hemolytic crisis develop within hours of the stress, and it can get precipitated by certain drugs. And well, the infections can be these hepatitis, rickettsial, typhoid, urinary tract infection, and typically a cola-colored urine can occur, and treatment includes high fluid and dialysis for hyperkalemia. In the end, pregnancy-related AKI is again occurs all over the world, but much more commonly in tropical countries. The obstetric AKI continues to be a very important part, though in India the contribution of obstetric AKI has declined to around 8 to 10%, but they about 20% of develop, especially when they occur in the third trimester. In the next slide, we'll talk about it. Can cause acute cortical necrosis, and they are actually dependent on dialysis for a long time. So you can have in the first trimester due to septic abortion, but in the late trimester, it is due to abruptio placental, severe hemorrhage, HELLP syndrome, acute fatty liver, and TMA of unknown mechanism. And these are certain differential diagnoses, but when transaminitis may be raised in HELLP syndrome, we know that it can occur in an acute cortical necrosis. It's a frequent progression. There can be lupus nephritis, which can occur in pregnancy, and these are the various causes, and schistocytosis occurs in HELP and HUS. So in the end, I would like to take you through this slide of algorithm of how to approach a patient. Of course, history, physical examination, blood and urine studies are the cornerstone. Well, you have to take a detailed step history, physical findings, try to find out what is the fractional excretion sodium, what is the urinary sediment, and divide these into either a pre-renal, intrinsic, or obstructive causes. And based on this, we have to identify, treat the underlying cause. I think hydration is very important. We have to improve the micro and macrovascular, glomerular disease, interstitial nephritis. If it is due to drug-induced, steroids may be there. Maybe then ATN, we have to support with dialysis. We have to give them specific therapy. If it is a snake venom, it is a toxin, we have to hydrate them. Then, of course, if the patient is not improving, we have to refer them to our colleagues in nephrology who will like to treat them. With this, I will thank, and I'm sorry if I have exceeded the time limit, but I thought it is an important topic, and each one of us should be aware about tropical AKI, which can be seen by each one of us, especially in this season when you have a hot tropical climate. Infections, I'm not talking about many other disorders like typhoid, like sepsis, which can also present with AKI. Thank you very much for your patience. These are some of the references. If you want to, I've already shared the slides with Dr. Pankaj, and you can take the slides on. Thank you very much.
Thank you, President Singh, for such a wonderful talk. I think he has practically covered every aspect of AKI which we see in tropics. Invariably, the early diagnosis is the key to the management. And I'll request from the house if any question is there, so that I think Professor NPC is still available.
Yes, sir. He's there.
Yes, sir.
Any
Dr. Gera,
question?
good evening. Can you hear me, Dr.
Yes,
Gera?
we can. Thank you, sir.
Right. Thank you.
Any question from the audience?
So I think this AKI is, sir, you can have the question.
Sir, Dr. NP Singh, I have one question.
Yes.
Can we preempt the development of acute kidney injuries in tropical disease like dengue, malaria? Or are there any markers before the development of AKI by which we can know that this patient is going to develop AKI?
So I think a very, very important question. What is important is to, have a high index of suspicion that one of the organ which can get affected in these tropical infection is kidney injury. Definitely, there are certain patient-related risk factors, there are certain disease-related factors which can make you aware that this patient is going to develop an AKI. Now, once the patient develops an AKI, then management essentially consists of hydrating them if it is a pre-renal, avoiding nephrotoxin agents, and if the patient has an established AKI, hyperkalemia, acidosis, then it requires dialysis. So, yes, you talked about an early diagnosis. I think there are markers which have been in vogue for last almost 1 decade, but unfortunately they have not been converted into a clinical use. Professor Kullar, who's sitting in front, knows that the MATS has started the cystatin C as an alternative investigative tool to detect AKI and CKD, but we do not know whether still we have these NGALs and early markers of kidney injury which can be made available. So I think we need to rely on our old age friend creatinine, but more importantly, if the patient develops an oliguria, patient has other evidences to suggest that this is going to develop AKI, then we should be able to diagnose them. Dengue, with Dr. Gera and Pankaj and Ashok, we were there when I was in Max. We had many patients who presented to us with AKI. Vivax now also causes AKI, while earlier it was supposed to be a benign disease, but now, of course, we know Vivax is as bad as falciparum, and of course, leptospirosis should always be thought of, and in India, all over, especially when we were in South, we were having these cases, but definitely in Delhi as well.
Thank you, sir. One of the pertinent question that comes up for physicians, sir, that sometimes the patient of tropical infections gets into anuric AKI, right? And patient becomes, dialysis dependent. So how many weeks, like sometimes patient takes longer time to recover. So is there any marker, sir, for those patients that would recover, the patient would be on permanent dialysis or for tropical infection-induced AKI, sir?
I think it's very important question. Many of these, especially snake bite related, pregnancy related or severe leptospira can cause what is known as severe ATN, or many of them can go into acute cortical necrosis, which can be patchy or which can be, full ACN. Now, of course, CT scan, non-contrast CT scan can rapidly diagnose ACN, but I think in my experience and others can pitch in, almost patients may require dialysis for almost up to 4 to 8 weeks depending on the severity, and many of these patients then suddenly open up. I remember when I was in Max, we had a case where we dialyzed for almost more than 2 months, and then suddenly one day he presented with polyuria and his kidney function improved. But even if their kidney functions improve after 2 to 3 months, they will have a residual serum creatinine which will be higher, and they have more chances of going into chronic kidney disease. But definitely I will give them 2 months time before I label sort of them as dialysis dependent. We can ask Dr. Kullar on this more.
Well, thank you, Dr. NP Singh, for excellent presentation. Dr. Kullar, anything you want to say or give comments about it?
Thank you so much, sir, for joining in with us. I request... Sir.
No question is possible after that masterly talk. I mean, you don't leave scope for any further information. Just to reiterate what you have said, yes, timely dialysis for these patients, that can certainly bring down the mortality rather than delaying it. We debate as nephrologists also when is the right time to initiate dialysis. I think it has to be on a case-by-case basis. But point well taken, if the recovery doesn't happen, and a very pertinent question asked, if it doesn't happen timely, obviously you become little worried and start thinking about cortical necrosis. You can get a clue from a plain X-ray abdomen or even a CT scan as early as 7 days. But obviously, the true diagnosis will come from biopsy. Short of that, a contrast-enhanced CT scan to look that there is no cortical flow. Obviously, you may not want to give contrast to a patient who is already oliguric or is anuric. So it's best is, and since the treatment is not going to change, you will have to patiently wait for the recovery, which is going to happen in majority of the times.
Thank you, sir. I think next time we expect Dr. N.P. Singh to be physically present here when we have conference. That is our request from EDPA. Thank you very much.
Thank you so much, sir. I would request the chairpersons to please proceed towards the felicitation.